Kanski lecture series, and this is going to be the acquired macular diseases part 10. And in this part, we are going to discuss about the microcystic macular edema. The microcystic changes of the inner nuclear layer, distinct from the classic CMO, can occur in eyes with optic neuritis and some other forms of optic neuropathy. So basically, these occur with the cases of an optic neuropathy or optic neuritis. It is believed to be caused by the retrograde degeneration of the inner retinal layers that manifest with an impaired fluid resorption. So because there are degeneration in the inner retinal layer. So next is a degenerative myopia or pathological myopia. So whenever the myopia is very high, it can cause the changes in the retina, which is certain features in the retina, which is known as a pathological myopia. Introduction. Myopia is the result of a complex hereditary and environmental factors. There is a strong evidence for the causative association with long-term intensive near visual acuity, particularly reading and using personal computers. So whenever there are use of a personal computers or a near visual thing, then there is a induction of a myopia. A refractive error of more than -6 diopters constitute a common definition of a high myopia. So anything which is greater than -6 is known as high myopia, in which the axial length is usually greater than 26 millimeter. It affects over 2% of the adult Western European or American population and may be as high as 10% in East Asian. Pathological or degenerative myopia is characterized by the progressive anterior-posterior elongation of the sclera envelope associated with the range of secondary ocular changes, principally thought to relate to the mechanical stretching of the involved tissue. So whenever there is an enlargement of the eyeball, it causes the changes in the interior and posterior part of the eye, known as pathological myopia. It is a significant cause of a legal blindness, with maculopathy the most common cause of visual loss. Low dose atropine 0.01% instilled at bedtime can significantly slow the progression of myopia in children. And now there is a new study which is known as ATOM study, and this study concludes that installation of 0.01% of atropine at bedtime can slow the progression of myopia in children. Although there is no consensus, a reasonable approach is to offer this treatment to children between the ages of the 5 and 15 years whose myopia is increasing at more than 1 diopter per year. These children should be encouraged to spend more times outdoor in sunshine. Table 14.4 lists systemic association of high myopia. So high myopia can be due to Down syndrome, Stickler syndrome, Marfan syndrome, prematurity, Noonan syndrome, Ehlers-Danlos, and Pierre-Robin syndrome. So these are the associations of the high myopia. So how do you diagnose a case of a degenerative or pathological myopia? Pale tessellated or tegroid appearance is due to diffuse attenuation of the RPE with visibility of the large choroidal vessels. So tessellated fundus is basically a fundus in which due to the RPE attenuation or thinning of the RPE, there is the visibility of the large choroidal vessel. So let's see figure 14.57. A is showing us, so you can see it is showing us a tessellated fundus. You can see the choroidal vessel visible in the fundus. Next is a focal chorioretinal atrophy is characterized by the patchy visibility of the choroidal vessels and often sclera. So there will be the visibility of the vessel as well as sclera. Anomalous optic nerve head. This may appear unusually small, large, or anomalous with a tilted conformation. So sometimes in the case of a myopia, the optic nerve can be small, they can be large, they can be tilted. Peripapillary chorioretinal atrophy is very common, most commonly as a temporal crescent of thinned or absent RPE. And there can be peripapillary chorioretinal atrophy with the temporal crescent. Acquired optic disc pit formation is not uncommon and is thought to be due to expansion of a peripapillary region as the eye enlarges over time. Next is the lattice degeneration can also occur in a case of a myopia. Lacquer cracks are the rupture in the RPE Brook membrane choriocapillaries complex characterized by the fine irregular yellow line crisscrossing at the posterior pole in around 5% of the highly myopic eyes and can be complicated by CNV. So whenever there is a rupture in the RPE and Brook membrane and choriocapillary complex, it is characterized by the crisscross line in the posterior pole, and there can be the formation of CNV in the lacunar cracks. So let's see figure 14.57. So B is showing us a focal chorioretinal atrophy. This is showing us a peripapillary atrophy and a tilted disc. This is a D is showing us a lacunar crack. So you can see that there is a yellowish line with a crisscross appearance. And this is a coin shape hemorrhage, and F is showing a Fuchs spot, which is basically when the coin hemorrhage resolve. Subretinal coin hemorrhage may develop from the lacunar crack in the absence of CNV. Fuchs spot is a raised circular pigmented lesion at the macula developing after the subretinal hemorrhage has been absorbed. Staphylomas is a peripapillary or macular ectasia of the posterior sclera due to focal thinning and expansion, present in about a third of the eye with pathological myopia. So sometimes you can see that there is an ectasia of the peripapillary or macular area, and this is known as the staphyloma. Association include macular hole formation and dome-shaped macula. Peripapillary intrachoroidal excavation formally described as a peripapillary detachment of the pathological myopia PDMPM may occur adjacent to nerve, commonly inferiorly. Clinically, it may be evident as a small yellowish orange peripapillary area, typically inferior to disc. It can usually be identified on OCT. Visual field defects are common and frequently mimics glaucoma. So let's see. So this is a degenerative myopia. PA is showing us a three-dimensional MRI scan showing us a posterior staphyloma. So you can see there is a posterior staphyloma. B is showing wide field image of staphyloma. Arrowhead marks the edge of the staphyloma. So this is an edge of the staphyloma. C is showing an intrachoroidal excavation. So this is an excavation. Arrow marks edge of the cavitation. And D is showing us an appearance of the intrachoroidal excavation. So you can see the cavities in the mostly choroid, and it can be visible on the OCT, and it is usually appear inferiorly in the retina close to the optic nerve head. So next is a rhegmatogenous retinal detachment is much more common in high myopia. The pathogenesis including increased frequency of PVD, lattice degeneration, asymptomatic atrophic hole, myopic macular hole, and occasionally giant retinal tear. So RRD can also occur in a case of high myopia, mostly because there are association of lattice degeneration. There can be increased frequency of PVD, there can be atrophic hole, there can be myopic macular hole, and sometimes due to the giant retinal tear. CNV can also develop in a case of myopia, mostly in the lacunar cracks. 10% of the highly myopic eyes develop CNV. The prognosis is better in young patients with myopia related CNV than in AMD. Anti-VEGF therapy is generally the treatment of choice. The injection frequency may be less than what needed for the AMD, but RD risk is higher. Macular retinoschisis, which is also known as foveoschisis, and macular retinal detachment without macular hole formation may occur in highly myopic eyes with posterior staphyloma, probably as a result of a vitreous traction. Some cases are associated with intrachoroidal cavitation. Retinoschisis may be mistaken clinically for CMO is better characterized by OCT than biomicroscopy. So sometimes there are macular retinoschisis can develop where there is a separation of the inner layer of the retina, and there can be with or without macular hole. Macular hole may occur spontaneously or offer a relatively mild trauma and is associated with the development of the rhegmatogenous retinal detachment, much more common than age-related idiopathic macular hole. So in a cases of a myopia, there can be the formation of a macular hole after the trauma. Myopic macular retinoschisis and myopic macular hole may be the part of some pathological process. Vitrectomy may be effective for both, but the best surgical technique remain undefined. Peripapillary detachment is an innocuous or yellow-orange elevation of the RPE and sensory retina at the inferior border of the myopic conus, anomalous optic nerve head complex. Cataract, posterior subcapsular or early onset nuclear sclerotic. So cataract can also be found in the case of a myopia. Glaucoma, there is an increased prevalence of a primary open angle glaucoma, pigmentary glaucoma, and steroid responsiveness. And myopia is uncommon but may develop when there is a significant difference in myopia between the two eyes. Dislocation of the lens, natural or artificial, is rare but well recognized risk. So next is an angioid streak. So angioid streak is basically the break in the Bruch membrane, which is mostly around the optic nerve head, and there are certain systemic association with angioid streak as well. Angioid streak are a crack-like dehiscence in brittle, thickened, and calcified Bruch membrane. So because the Bruch membrane is brittle and thickened, it can cause the crack, and so angioid streaks are caused due to that. Approximately 50% of the patients with angioid streaks have a systemic association. Pseudoxanthoma elasticum, a hereditary disorder of connective tissue in which there is a progressive calcification, fragmentation, and a degeneration of elastic fiber in the skin, eye, and cardiovascular system, is by far the most common association of angioid streak. Cronblatt-Strandberg syndrome. Patient develop a plucked chicken appearance of the skin, most commonly on the neck, axillae, and antecubital fossa. So pseudoxanthoma elasticum, PEX E, also known as, is very common disorder which is associated with an angioid streak. And because there is a progressive calcification, fragmentation, and degeneration of elastic fiber in the skin, eye, and cardiovascular system, so in the skin it causes changes like there is a plucked chicken appearance of the skin, and most commonly involve the neck, axillae, and antecubital fossa. Approximately 85% of the patient develop ocular involvement of a variable severity, usually after the second decade of life. Then there is a Paget's disease. So most of the time the mnemonic for angioid streak is Pepsi, which means that Paget's disease, Ehlers-Danlos syndrome, pseudoxanthoma elasticum, sickle cell disease, and other disorders, idiopathic as well. Paget disease is a chronic progressive metabolic bone disease characterized by excessive and disorganized resorption and formation of bone. So bony formation and resorption is disorganized. Angioid streak occur in about 2%. It is thought that calcium bind to elastin of the Bruch membrane, imparting brittleness and fragility. So calcium binds to the Bruch membrane and it causes the brittleness and the fragility. Hemoglobinopathies occasionally associated with angioid streak are numerous, including sickle cell trait and disease and thalassemia. In these, a brittle Bruch membrane is thought to be due to iron deposition. Miscellaneous other associations have been reported. There is probably no link between the angioid streak and Ehlers-Danlos syndrome. So diagnosis is sign is basically gray or dark red linear lesion with irregular serrated edges that intercommunicate in a ring-like fashion around the optic disc and radiate outward from the peripapillary area. So basically they appear as a gray or dark red lines and starting from the optic disc in a radiation like fashion. The streak tend to increase in width and extend slowly over time. Pudgy orange skin, also known as leopard skin, mottled yellow speckling is common, particularly in cases associated with pseudoxanthoma elasticum. Optic protrusion are frequently up to 25% associated. So optic protrusions are also present with the case of an angioid streak. Scleral depression is relatively contraindicated in these eyes due to the risk of a further damage to the Bruch membrane leading to the new angioid streak or choroidal rupture. So basically you prevent the trauma to the sclera because it can induce complications of the angioid streak. So this basically there are three major complications of angioid streak. Number one is that there can be choroidal rupture, there can be the CNV formation, and there can be the foveal involvement. So the angioid streak are typically asymptomatic at first. Visual impairment occur eventually in over 70% of the patient. CNV is by far the most common cause of visual loss. Choroidal rupture may occur following relatively trivial trauma. Foveal involvement with streak. So investigations include the red-free photography demonstrate the streak, FA show hyperfluorescent window defect due to RPE atrophy overlying the streaks associated with variable hypofluorescence corresponding to RPE hyperplasia. FA is generally indicated only if CNV is suspected. Streaks are autofluorescent. They are often more extensive than clinically, which may confirm the diagnosis. In subtle cases, puree d'orange is shown. So, fluorescent angiography also shows the window defect because of the show hyperfluorescence due to the window defect due to RPE atrophy, and there can be the hypofluorescence due to the IPE hyperplasia, and the streaks are autofluorescent. So, how do you treat the cases of the angioid streak? Following systemic investigation where appropriate, usually via referral to an appropriate physician observation is the approach. In most cases, patients should be warned against the precipitating in contact sports and advised to use protective spectacles when necessary. So basically major thing is to avoid the trauma, and only we treated CNV if there is a CNV associated with angioid streak, we treated with anti-VEGF agent. CNV should usually be treated with intravitreal anti-VEGF agent but commonly recurs or develop at a new site. So this is an angioid streak. So you can see the red gray streak arising from the optic nerve head in a radiation like fashion. B is showing puree d'orange temporal to the macula. C is showing angioid streak and optic discrusion. D is showing infrared image of the patient in C. E is showing subretinal hemorrhage caused by the traumatic choroidal rupture. F is show hyperfluorescent streak. So due to hyper window defect, so you can see that there is a hyperfluorescent on fundus on angiography, fluorescent angiography. So next is a choroidal fold. So choroidal fold is basically the folds in the choroid. Most of the time it is due to the hypotony of the eye. So introduction: choroidal folds are the parallel grooves or striae involving the inner choroid, Bruch membrane, and the RPE, sometimes the retina, chorioretinal folds. So mostly there are folds in the inner choroid, Bruch membrane, RPE, and retina. They are likely to develop in association with any process that induces sufficient compressive stress within the choroid, Bruch membrane, and retina. Primary mechanisms include choroidal congestion and scleral compression, and occasionally tissue contraction. So whenever there is a choroid is congested, there is scleral compression. Choroidal folds should be distinguished from the retinal fold, which have a different pathogenesis, usually ERM. Causes include idiopathic papilledema, orbital disease, and ocular disease. So idiopathic congenital folds may be present in healthy, often hypermetropic individual in whom visual acuity is typically unaffected. So it usually present in a hypermetrop individuals. The folds are usually bilateral. A symptom of idiopathic acquired hypermetropia with choroidal fold has been described in these patients. Elevated intracranial pressure should always be excluded even without evident papilledema, although a constructed scleral canal causing optic disc congestion has been proposed as an alternative mechanism in some patients. Papilledema: choroidal folds may occur in patients with a chronically elevated intracranial pressure when they may be associated with reduction of a visual acuity that may be permanent. So it can also occur whenever there is a papilledema. Orbital disease such as retroorbital tumor in thyroid ophthalmopathy may cause choroidal fold associated with impaired vision. Ocular diseases such as choroidal tumors, inflammation such as posterior scleritis, scleral buckling for retinal detachment, and hypotony can also cause the choroidal fold. So what are the diagnoses? The effect on the vision is variable and dependent on the cause. Many patients are asymptomatic. So signs are there are parallel lines or grooves or stria located at the posterior fold. The folds are horizontally oriented. So most of the time the folds are horizontal oriented. The crest, elevated portion of the fold, is yellow and less pigmented as a result of stretching and thinning of RPE, and trough is darker due to the compression of the RPE. So there is a crest and there is a trough. So crest is due to the fold elevated portion, and it is usually is yellow and pigmented, whereas trough is darker due to compression of the RPE. Clinical examination should be directed towards the exclusion of the optic disc swelling as well as other ocular or orbital pathology. So one should rule out the cause of the choroidal fold. OCT allowed the differentiation between the choroidal, chorioretinal, and retinal folds. FA have typically demonstrated the fold that may show associated atrophy. If this is marked, the appearance can be mistaken for angiometry. Fluorescent angiography show hyperfluorescent crust as a result of an increased background fluorescence showing through the stretched and thin RPE and hypofluorescent trough due to the blockage of the choroidal fluorescence by the compressed and a thickened RPE. So the crust will develop, will see as a hyperfluorescent, and trough will appear as a hypofluorescent. Supplementary imaging, ultrasound, computed tomography, and MRI scanning of the orbit or brain may be indicated in elevated intracranial pressure or acquired hypermetropia with choroidal fold, and enlarged perineural space may be noted on B scanning and MR of the optic nerve. So this is a choroidal fold, so you can see that there is a striation in the choroid and they are usually horizontal. So next is a hypotony maculopathy. So due to hypotony or decreased IOP, there can be the maculopathy. So maculopathy may occur in eyes developing hypotony, defined as a less than 6 millimeter mercury. The most common cause is excessive drainage following a glaucoma filtration surgery, particularly when antimetabolite has been used at the time of the surgery. So whenever there is a very overfiltration, it is known as a hypotenuse maculopathy. Other causes include trauma, cyclodialysis, cleft, penetrating injury, chronic uveitis by directly impairing the ciliary body function, and by the tractional ciliary body detachment due to cyclitic membrane and retinal detachment. So other causes can be like there can be due to trauma, uveitis, ciliary body detachment, and retinal detachment as well. So these are all cause the decreased IOP. Systemic causes of hypotony, usually bilateral, include dehydration, hyperglycemia in uncontrolled diabetes, uremia, and treatment with hyperosmotic agent or carbonic anhydrase inhibitor. So these also can cause the hypotony, but they usually cause bilateral hypotony. The development of secondary choroidal effusion may act to perpetuate the hypotony. With time, the hypotenuse process can itself lead to further damage, including sclerosis and atrophy of the ciliary processes. Prolonged severe hypotony may lead to phthisis bulbi and loss of the eye. Treatment to restore the normal IOP is directed according to the cause. Diagnosis: visual acuity is variably affected. Delayed normalization of the IOP may result in a permanent visual impairment, though substantial improvement has been reported following reversal of the hypotony after several years. So visual acuity is variably affected, but if you delay normaling the IOP, it can cause the permanent damage. Fine retinal folds radiating towards from the fovea, which may also show CMO. There can be chorioretinal folds may radiate outward in a branching fashion from the optic disc. These are due to scleral collapse with resultant chorioretinal redundancy, so there can be choroidal fold formation. Miscellaneous, a variety of other features may be present related to both to etiology and secondary effect of hypotony, including shallow anterior chamber. So there can be shallow anterior chamber, there can be choroidal effusion, there can be cataract, corneal decompensation, optic disc edema, uveitis, wound leak, or an unexpected filtering bleb adjacent to wound. Following cataract surgery, there can be cyclodialysis, cleft on gonioscopy, and retinal detachment. Ultrasonic biomicroscopy may show a cyclitic membrane or cyclodialysis cleft if there is a clinical reason to suspect this. So if the cause is uveitis or cleft, so you can detect it by ultrasound biomicroscopy. B-scan ultrasonography will demonstrate choroidal effusion. A-scan ultrasonography or interferometry may show reduced axial length. So this is a hypotony maculopathy, show the cystoid macular edema. So that's it for the part 10. See you in the next lecture.